talk about quite a broad subject. The investigation of thyroid nodules is bound to have now in the exam. It's no.
No, we were doing this last time, Sarah. It's not opening PowerPoints now. No. Is it logged in as presentation?
Yeah, it's in presentation. Just go to... So I can pop it on for you. Do you want to...
It was working earlier.
Yeah.
So yeah. Anyway, so you're bound to have a question in the exam, from this. Do I need to ask you to
Yeah.
just to?
Just use that clicker.
And did I point it to you?
No, I just should pick it up.
Okay. So yeah, thank you. Yeah. So yeah. So you're bound to have basically a question of this in the exam, and also if you are appearing for the European exam, also that's basically been introduced in the syllabus. Obviously, if you change career and if you want to do endocrine surgery, you will also get it anyway. So this is basically where I work. That's Guy's Hospital here. Sorry, not this. This is the chart, obviously. Guy's Hospital is actually here. This is the highest building in Europe, so it's very easily recognizable. So you fly over London, you land into Heathrow. You usually often turn around here, so you'll be able to see us from the top. This is we coming from basically a place where there's a lot of pedigree of endocrine and oncological disease and management. So this is William Gull, who first described hypothyroidism. He was basically a physician from Guy's. This is Thomas Addison, who described Addison disease as also a physician from Guy's. And this is actually Thomas Hodgkins, who obviously described Hodgkin's disease and also a physician from Guy's. So it is a huge pedigree of endocrine and oncological surgery. So I'm going to talk about thyroid nodules, thyroid cancer, basically how we approach all this. So basically, thyroid nodules are very common. If we in this audience we put a scanner. Basically, 30% of men will have a thyroid nodule, and then if we scan women, between 50 and 70% of women will have a thyroid nodule. Obviously, the majority are going to be benign. And obviously, we'll need to really watch out just towards those to have basically a problem, and so therefore we need to basically be able to address them. So it's become a really huge problem in the UK because quite a lot of the time patients, they go to the GP with a little bit of a neck an issue, they get an ultrasound. Basically, that's both my uncle. So it is a very, 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 very common problem. As you know, the incidence of thyroid cancer actually increased significantly in the kind of basically in the past 30 years, especially since Chernobyl. In Europe, we've seen basically a dramatic increase, and that was we think that's probably in Europe, as I said, that's a turning point. However, if you go to Australia or the States, it's also been a significant increase in thyroid cancer, and it is usually probably likely to be basically a multifactorial issue. As I said, basically because patients get very aware, basically because we have a lot of ultrasounds done for other reasons, and they'll pick up thyroid nodules. There's probably a true incidence in certain places, and it also we now obviously we see it much more rapidly. Whereas before you had a lot of patients with long-standing basically thyroid nodules who had never seen a GP. And so therefore they were probably not diagnosed because of the truth is that quite a lot of these cancers, they may not clinically manifest. So thyroid nodule is basically a clinical entity, and it can be all these sort of kind of basically things. So you've got to be very in mind that what you were trying to do is we're trying to basically exclude the possibility of thyroid cancer, but also as a holistic sort of basically physician or surgeon, you need to be able to basically address all these conditions too. So in terms of kind of guidelines, the BTA is made very clear recommendation as to when to refer thyroid nodules. Obviously, we're going to basically see really the majority of this 2-week cancer weights, where there's basically been a significant kind of concern from the GP and from the patient, where there's basically an associated lymphnopathy, that the thyroid nodule is rapidly enlarging, or there may be a kind of a significant upper airways obstruction or recurrent laryngeal nerve involvement. But then we'll probably still see quite a lot of them in front of basically a doubt. The GP basically they do refer these patients through the 2-week cancer weight. Therefore, we'll end up seeing a huge amount of these patients. So obviously there are very clear clinical features associated with thyroid cancer, and this is actually something that you will need to know for the exam, and they're basically in every single basically guideline. When we get patients from the GP, we need to make sure that they do get good information. Then maybe they should really explain the patient what the cancer risk, and also they should ideally give an idea of the limitations of those diagnostic tests, especially if the ultrasound is actually done by a radiographer in a district general hospital where things are not probably categorized properly. In terms of basically the clinical approach, and that's basically something for those who sit the exam, you need to take a really good history. And as I said, we need to make sure you don't just focus on the thyroid nodule, but also focus on all this that may be already relevant. So in terms of basically the checklist, that's basically what you need to have a look. And in terms of the clinical approach, again, you need to really be thorough. You need to really have a look at, make sure that the patient hasn't got, especially if they come primarily to your clinic, they make sure that they don't have any signs of basically hypo or hypothyroidism that they may need to be addressing quite urgently. And then obviously, as an ENT surgeons, we're always going to do a fiber optic nasendoscopy where we're going to see the stages of the vocal cords. And I think it's actually quite useful to really do right at the beginning for anything, so that status is basically checked. And obviously, no doubt in patients who have got upper digestive tract symptoms or big goiters. In terms of the investigations, we're going to basically do thyroid function test and thyroid antibodies. These kind of investigations, we will do it in very specific, basically situations. In Oriental countries, sometimes they do thyroglobulin, especially in Japan. We don't really do them in here. And basically, what we're going to do is we are going to send the patient, or if you could do it in your clinic yourself, as a gold standard, what we're going to do is we're going to do an ultrasound guided fine needle aspiration cytology that hopefully will give us the diagnosis. It is actually very good. Obviously, the ultrasound characterizes the nodule, but also aids the sampling, and so it decreases the sampling error significantly. And then basically that also, done in appropriate places, can actually reduce the rate of inadequate samples down to almost kind of zero. And certainly that's basically what we did by centralizing the service and getting the proper kind of expert radiologist, cytologist on site. We managed to get the rate of inadequate samples from 20 to 2%. So it is actually very good. You can actually see here, for instance, this is basically the needle going into that nodule. The nodule has got a cystic component in the middle, and you got basically a solid component at the top. If you just basically do it blindly without the aid of the ultrasound, you may just get cystic fluid, and you may not get a diagnosis, and therefore your sample is going to be inadequate or non-diagnostic. Whereas if you then see this picture, then you will take some fluid from the nodule, or from the cystic component, but also you can then redirect your needle into the solid component, and you're likely to get a better yield in terms of diagnosis. The BTA now has basically established a very, very good system for the characterization of thyroid nodules, especially obviously from the ultrasound side of things that follow the cytology side of things. It follows more or less what the American guidelines have established, and also the EU thyroid, which is the European guidelines. So they basically give you a number of potential characteristics that you need to basically theoretically record on your report, and that's why sometimes it is a little bit lacking. And this is basically just something that they provide in order to give the radiologist and the radiographers basically an indication as to what can be done, how we actually grade it. So you can actually see here, the U5 characteristics, where you have basically microcalcification, irregular borders. You got basically taller than wide. So all these characteristics are indicating potential malignancy. So it is actually much easier then to characterize and then put a label on these nodules. Obviously, this has been going on for a long time. This is actually something that you really need to do need to know for the exam. It's in the guidelines, but basically the cytological classification, it goes from Thy 1, which is basically non-diagnostic, to Thy 5, and then in the British Thyroid Association guidelines, then you get basically just an action associated with it, which is actually makes it easy. So anything that is actually just above Thy 3F, it needs to go and have surgery. Anything below that, you need to then obviously consider in terms of what the potential clinical indication for surgery is. The radioisotope studies is something that when I started as a consultant 20 years ago, it was done quite widely for the evaluation of thyroid nodules. We don't really do them anymore. However, if you have somebody who has got abnormal, if it comes primarily to your clinic, to the head and neck clinic, if it does got abnormal thyroid function test, especially if you've got suppressed TSH, it's actually quite useful to do, because then it will characterize the type of overactive thyroid that this patient has got, whether he's got a solid toxic nodule, where he's got Graves' disease, or whether he's got basically a multinodular toxic goiter. So it is actually quite useful in certain circumstances, but not for every single thyroid nodule. The same for the CT scan is basically in a staging investigation. Obviously, if you see big goiters with suspected retrosternal extension, or you see cancer, especially with cervical lymphadenopathies, you will do them, and it is a really an excellent, gives you excellent anatomical definition. We scrap the issue about not giving contrast. We normally give now contrast to everybody. If you have somebody with a normal renal function, the contrast is basically gone in 6 weeks. By the time the patient is basically get treated and he needs to have iodine, that shouldn't really be a problem. So we will really like to have that really nice anatomical definition, and the contrast will give you really that. And if you do it without ultrasound, without a contrast, then you will get nowhere or very little. Some units, they use some MRI scan. In some units, it's been preferred to if you have cancer to do an MRI scan. Obviously, it's got a lot of advantages. Mainly that it doesn't have any irradiation. It doesn't actually you need to give any iodine contrast. So that means that there's no kind of problem in terms of then these patients getting iodine at short notice. But however, it just causes a problem with motion artifact. The patients stay there for a long time, and then sometimes the anatomical definition is not as good. So it's actually much easier to get good images with CT scan and iodine contrast that is actually with MRI scan. So you need to bear that in mind. When are we going to indicate surgery for thyroid nodules? Basically, these are the list, and basically we already see them. Obviously, if you have an abnormal fine needle aspiration cytology, whether the patient has got a low history of irradiation, especially a lot of patients from Eastern Europe, for instance, if they have a kind of a nodule, they may be non-diagnostic, you will probably need to kind of bear that in mind. If you have basically a complex cystic solid lesion like the one we saw earlier, that is more likely to have cancer in it. And obviously, if you have clinical symptoms of malignancy, and also for those kind of very rare patients where they fall into a multiple endocrine neoplasia type of bracket. This is basically the big lady. We're just going to do her next week. She's got a big thyroid nodule. She's got tracheal deviation, but she's got a lymphadenopathy here. So what do we do with Thy 3As and Thy 3Fs? The risk of malignancy in each of them is actually been very well established. We did a paper which was published in the BJS in 2010, and then we saw that for the Thy3Fs, we got basically a rate of malignancy of around about 29%. If we have basically on the other contrary a Thy3A, the rate of malignancy is actually less than 10%, which is basically the average kind of really thyroid nodule. So for all those Thy3A where they do not have any radiologically concerning features, we can actually potentially consider follow-up or not doing anything. If you have a Thy3F, then we'll have much lower threshold to doing surgery, which we're going to discuss a little bit later on. And obviously, all these patients, they need to be discussed at the MDT, which can be a little bit of a kind of a burden, but on the other hand, it's actually very important because then we can have basically a corporate decision for them. The one thing we need to kind of also bear in mind is that the patients who have got follicular neoplasms doesn't mean that they have follicular cancer specifically. This is basically from that same paper, and you can see the majority of follicular thyroid lesions or neoplasms, they'll be basically papillary thyroid cancers. That means that, you know, the follicular kind of bracket or label that they have is because that neoplasm is coming from the follicular epithelium, not because it's going to be either follicular adenoma or follicular carcinoma. So you've got to bear that in mind, and especially for when you are addressing your examiners. So the Thy4s, it's actually quite you know, nowadays, you know, the majority of good cytologists, they will diagnose cancer and they put the bracket of Thy5. But the ones that they have Thy4s, you've got to really be very careful, because that means that they're seeing high grade kind of features, but they don't actually then they cannot really in a way characterize them as the most common cancer, which is basically the papillary. Sometimes they do, but so you got to bear in mind, because they can be, you know, things like polydifferentiated thyroid cancers, they can be lymphomas, they can be medullary thyroid cancer. So when they give you a kind of Thy4, you need to really be very careful. For instance, you know, if you have a Thy4 with a spindle cell kind of features, you will ask for a calcitonin, for instance. So you need to really basically put that in your mindset. So what are we going to do with the Thy4? So if they are low-risk patients and the nodule is less than 4 centimeters and they are benign or indeterminate kind of features on the ultrasound, you can do a lobectomy, obviously in some of these patients, unless there is actually something that the patient kind of wants. If you are going to be, if they are high-risk patients or they have kind of basically a multinodular gland, you can actually go and do a total thyroidectomy straight away. The risk, the rate, the role of frozen section, I wouldn't probably recommend it, but some people do, especially if you go to visit the Mayo Clinic. They do everything on frozen sections. We don't. I think it's actually very difficult really characterize things on frozen sections, and certainly very experienced histopathologists will tell you that in the UK. Then obviously you got all this kind of thing about kind of basically thyroid cancer, about all the different mutations that they do have. This is basically not the remit of this, but just to bear in mind that basically the thyroid cancer, the way that the thyroid cancer develops is the kind of the rate of mutations that these cancers they have is actually huge, and this is just basically it's just a small proportion of them. Another thing that they will, you will basically see a lot of on clinics is the Multinodular Goitre. It's basically, you know, something that is actually very common. The risk of malignancy in these goitres is around about kind of 8%, but depending on the area and the paper that you actually look, it can be from kind of basically 5 to 35. So in endemic areas, that is actually much higher. And then if you have a basically specific dominant nodule, which is clinically hard and so on, then the risk of malignancy is even higher. So the indications of surgery will be what we have. So if you have basically an abnormal FNA, you'll do that. If you have thyrotoxicosis, you have intrathoracic extension, or if the patient has got compression symptoms, you will have you'll indicate surgery for these patients. The kind of the approach to this is that there's a lot of patients that they have obviously multiple nodules, but if you have basically, that's my kind of rule of thumb. If you look at in the literature, there are people who basically share that view. Some people not necessarily do, But people like, for instance, Greg Randolph in Boston, shares that view that if you have basically a unilateral growth, you will do a lobectomy with his mastectomy. If you have bilateral growth, like in this patient here, you will then do a total thyroidectomy. The great majority of patients with multinodular goitres, they tend to have basically a dominant type of nodule. They don't have, huge bilateral kind of growth. In a way, it appears that some of these dominant nodules basically take charge, and then somehow they do suppress the rest of the gland. The other big issue is obviously thyroid cancer. This is something that you can get in any book. The majority are going to be papillary thyroid cancers, well-differentiated thyroid cancers. The majority, they do present as a solitary thyroid nodule. That will be the majority. However, you need to really bear in mind that thyroid cancer can present in any of these kind of variations. So you can have, patients with cervical lymphadenopathy, thyroglossal cyst. Obviously, patients with long-standing multinodular goitres, they could potentially kind of develop. Quite a lot of the time, a lot of patients that they have long-standing multinodular goitres, they'll say, is that nodule can actually develop into cancer? And probably the answer is actually no, but then you can actually develop cancer within that gland. Okay, and then so that's something that you probably need to know too. Now, in terms of cancer management, we tend to kind of basically be in many areas of medicine, we try to basically de-escalate. And so basically now, the majority of guidelines will recommend that basically for T1 and T2 disease in a low-risk patient, and then the low-risk patient, which is basically women and the age, is now the low risk is actually moved from 45 to 55, and that's in the version 8 of the TNM. So you got to also need to know that for the exam. So it's actually changed. This actually changed kind of really significantly, and then is something that you need to really bear in mind. So just going back to what we normally do in broad kind of terms, is basically for T1s and T2s. So in a low-risk patient, you will be sufficient for a total a lobectomy. However, if your patient have got multicentric disease, then you may need to then convert that. So if you do any of those patients and you normally recommend a lobectomy, then you got to bear in mind that you got to tell them that at some point in time, or if we find multicentric disease or any kind of adverse features, we may need to then convert into a complete thyroidectomy. So that's something that it's important that basically the patients know. And then obviously we'll follow them up, usually with ultrasounds, and then normally now the recommendation, because the rate of thyroid cancer is actually so big, we will have to basically do a cutoff, and then for low-risk patients, for T1 and T2 disease, which has been treated and they have no contralateral features or nodules on the other side, we can probably just follow them up for 5 years, and that's it, although that's still quite controversial. And obviously, if you have, for the rest of the patients, if they have multicentric disease and they are high-risk patients, then the majority of these patients will have a total thyroidectomy, and then they will be followed up with radioiodine and TSH management, not TSH suppression, but management. And then also the rate of radioiodine ablation is also been de-escalated, and we do have basically a couple of trials now assessing the need of patients or the benefit of patients undergoing radioiodine ablation. And then basically what is also been introduced in the guidelines is that we're going to do what we call a dynamic risk stratification. So we're going to, we'll have basically a TNM staging to start with, but then the patient is going to be on a bracket afterwards, depending on the histology and also the initial radioiodine treatment, and then we'll then follow them up for a different period of time. And so we do that straight away. Just another couple of things, which is basically the incidentalomas. This is actually something that is huge now. As I said, quite a lot of patients who go to go an ultrasound for neck pain or for globus or whatever, they'll get an ultrasound, and the chances are, especially in women, that 2/3 are going to basically find a thyroid nodule. So the problem is actually really, really huge. So you need to really bear that in mind. And also quite a lot of the time, if you have basically a good radiologist or that you get that report, then you can actually reassure them and then basically hopefully discharge them without no further action. The other thing that we have a lot of the time is in, especially in hospital, is the uptake after PET CT scan. A lot of patients, they get, with melanomas, lymphomas, sarcomas, they do get a PET CT scan at some point as a part of their either initial workup or as a part of the follow-up, and then quite a lot of them will get will have a positive nodule, an uptake in the thyroid gland, which can be, in the majority of cases, will be indolent. However, if the uptake is very hot, that means that the SUV, which the standard uptake value is more than 9% or 9, then you'll have to really be very careful that patient has got a thyroid cancer, and therefore you will need to probably investigate that further, depending on also on the clinical context. So if you've got somebody who's basically, which is not uncommon, that they will ask you, well, it's just this patient is assessed for palliative treatment or is put on a trial, and then you get a pickup of this is not going to kill the patient. So you've got to really put that in context too. So how we actually manage incidentalomas now? So they are obviously, they often, kind of a standard neck, they are less than 1 centimeter, so we're not going to be able to palpate that. Now in the American guidelines has been quite ruthless. Whether that's sort of kind of happening in individual cases or not, that's another matter. But basically, if you have something that is less than 1 centimeter with no adverse features, they can discharge those patients, and that's the end of the story. Whether that's true or not in real terms, I don't know. In the UK, we have basically, if you have anything less than 1 centimeter with no risk features, so benign features, you could potentially discharge those patients too. And then the problem is sometimes these things are not characterized properly. There's a tendency for, let's say, radiographers to be on the kind of in the caution side, and then basically call this indeterminate, and so therefore they'll come to the 2-week cancer weight, and then you will have to kind of basically reinvestigate them again. Now, if you try to kind of needle anything that is less than 5 millimeters, is going to be a really, really big problem because the accuracy is very, very, very low. However, in some specific circumstances, you may find micropapillaries who are, can sometimes behave aggressively. So if you've got something like between 5 and 1 centimeter with very, very obvious overt malignant features, you could potentially needle them. So in terms of the surgery, I just want to kind of give you just two or three concepts. So basically, I really do hate the concept of diagnostic lobectomy, which is basically something that we do all the time. And in the UK, that's what we say. And if you look at the guidelines, the only kind of the only guideline that has recognized the term as diagnostic is actually the British Thyroid Association, which I think is actually wrong. So people think that by doing a diagnostic lobectomy, that's it. So you can just take the nodule out and that's it. But you need to really address that hemithyroid, very clearly. So you want to really do a total lobectomy with a mastectomy. You want to explore that level 6. You want to preserve the recurrent laryngeal nerve and the parathyroids and not leave anything in the upper pole or in the pyramidal lobe. So we really need to treat that as a proper oncological operation, which is something that maybe quite a lot of these patients may end up having. So you need to really, when you do this diagnostic kind of thing, you need to do it in a therapeutic kind of mind, and then you do a proper oncological operations. Just 3 things about the technical tips, and it's obviously not the remit of this, but basically you need to really address the vascular pedicles properly. So in the upper polar specifically, you need to address each individual vessel individually, There's a lot of kind of basically thyroid tissue between those vessels, and then by addressing the upper pole and identifying and ligating each individual vessel, you will decrease the risk of postoperative hemorrhage. You will decrease the risk of damaging the external branch of the the superior laryngeal nerve, and also you will decrease the risk of leaving some thyroid remnant. So that's very, very, very important. I don't need to tell you anything about the recurrent laryngeal nerve. That always needs to be identified. Obviously, there's different ways of identifying the nerve. You can actually, depending on the pathology, you can actually identify it in the cricothyroid junction, laterally, which is the majority of the time, or inferiorly. But you will need to really always identify it, make sure that there's actually, you check the status of the nerve. And then by and large, we will recommend that you use intraoperative neuromonitoring, which again, we can discuss basically later on when we do the case discussions. And then also the parathyroids. So you will, again, that concept about diagnostic lobectomy and then just take the nodule out and that's it. You need to make sure that you do preserve those parathyroids. You need to be able to identify them. Obviously, some of the times it's difficult, especially in the lower pole, especially if they are embedded in the thyroidemic ligament. But most of the time, you'll be able to preserve the superior parathyroid gland, which is basically going to be just behind that nerve. So when you actually separate, you mobilize the lobe of the thyroid into the medial aspect. So you'll have basically the nerve going across there, and you'll have the superior parathyroid here arising from the inferior thyroid artery, and then the inferior one is normally going to be in front. You can actually do surgery for just a single nodule in the isthmus, and then in that case, if it's just less than 4 centimeters and it's basically right in the middle of the isthmus, you don't really need to do anything more, and you don't need to basically explore the gutters, and that will be the only kind of indication for that. When do we discharge thyroid nodules? Well, I think obviously, we can really possibly follow up two-thirds of the population. So we'll have to basically, at some point, we'll have to basically discharge them. And then if you have any clinical concern, because we cannot really, as I said, we cannot really follow them up forever, you need to basically make a cut. Usually for anything that you decide not to operate is about 6 months or maybe a year. And then you need to also make sure that you document that properly. And if the patient has got any concerns, you need to give them a specific written information about the risk of malignancy or the risk of potential transformation. And then they can come back straight away. And then usually with a 2-week cancer wait, they are there on a flash. But very rarely you'll see them unless actually something changed. So just to wrap things up, obviously thyroid nodules are very common. The ultrasound guided FNA is now the gold standard. We've got a really, really good, robust classification, which is in par with all the international guidelines. Do CT and MRI scan only for planning surgery and for anatomical and staging investigations. Obviously, your selection in terms of patients are going to be very important. The minimum proper operation is a lobectomy, and when don't use that kind of term diagnostic. Make sure that there's actually a proper therapeutic lobectomy, because that's is the only thing that you may need to do. Obviously, still a lot of controversies and a huge amount of basically research to do. So, thank you very much. Okay.
Thank you.
Yeah.
Thank you.
That's very kind.
Thank you very much. Thank you. So that's it for the morning session. We are now going to break for lunch. Now that